interact because we are going to learn a little bit more in communication skills. So, hope to hear from you all in between. So today we'll be dividing the presentation into two parts. The first part we will talk about how to communicate the bad news, and in the second part we will see how to deal with a particular situation that we all come across almost every day in your clinical practice. So we'll see how it. So what do you mean by the term bad news? Generally, we have something which is unpleasant that we are about to receive. It can be about a life threatening illness, it can be about an exam result that we are expecting, or something which we don't really or not ready to receive from someone else. And do you think you need a special skill to communicate the bad news, or is it needed to learn how to break the bad news or how to communicate the bad news, or just tell them that honestly, like what is happening, what is the news that you have, if it is a cancer or any life threatening illness, can we just tell like that, or do we need to have special skill to communicate the bad news? I'll look for the chat or your response. Why do we, or do we actually need a skill or training to communicate the news to them? So yes, we need a little bit of training how to communicate the bad news. So this is a scenario that we come across very commonly in many of the setting. This is the 38-year-old female recently found out that the biopsy report came out to be cancer. So how exactly will you tell this diagnosis? What will you tell the patient? I need response from everyone. Like how will you tell this patient that she has cancer? Either you can unmute or we can all type it in the chat. There are almost 28 participants, so I'm expecting 28 responses. Like, how exactly will you convey this diagnosis? So I can see, no, no, I saw a response called FNAC. So the report is confirmed. We did a biopsy, it came out that it is cancer. Now we have to tell the patient that they have cancer. So how will you tell her, a 38-year-old female, that she has cancer? What exactly the sentence that you use, or what will you tell her basically? Sorry. So I'm just asking. Yeah, I can say see one more response. Yeah. So Shiny is telling we can tell the possible way of treatment first. So, for example, like this, right? So you have an illness. It is you can go through radiotherapy. You may need a surgery and radiotherapy because this is cancer. So Evangeline is telling, explain the diagnosis and its prognosis. Okay, Sister Kanjan is telling that we need to build a relationship to gain her confidence. Thank you. And Liana is telling that we need a private setting, a share, not in a public or open space. Maybe ask or make sure that there is a close family or friend. Give time, understand, and create a plan together with her options. Thank you, Liana. So others can keep sending. I'll read in between. Yeah. Richa is believing that we should tell her close one first and then ask whether uh, to go further. Can we tell like this? Is it okay? I have seen the reports and you seem to have cancer. So, in a very private setting, in a room where there is no one, where I have the patient sitting in right front of you, in front of me, I have the reports. No, Shiny is telling outright no. Right, Shiny? No, this is not the way. I have been honest. I didn't tell anything. I was just telling that I have seen the reports and you seem to have cancer. Why do you feel that it is not the right way? Did you feel something bad about it? Because I'm so honest. The patient wants to know the diagnosis, right? No. Richa is also telling no. Open answer. Yeah. So because it's a news, I have to share, right? So that's why I told you have cancer. We have been talking about patient autonomy, right to know, and everything. So I'm just telling the patient that this is the diagnosis. So, what is a bad news? So, we'll come to that one by one. What exactly do you mean by a bad news? When you tell a bad news, what the patient feel is that they are in a situation where there is no hope at all, especially with this kind of diagnosis. Generally, even if it is a hopeful situation, even if it is a curable cancer, most often they feel the first feeling that they go through is that complete hopelessness. Okay, and generally it's a threat to their mental or physical well-being. It is a news which can actually affect their mental well-being. You are delivering such a news that can change their life from this minute onwards. Patients often tell, I just heard the word cancer, then everything was blank. I didn't hear anything else. Then the doctor and the nurse kept telling something, but I just did not understand or don't remember what exactly they told because I was still stuck with the word cancer, which came in the beginning. And this is a news which can actually affect their day to day living. They may have to stop going for their job, they may end up in having pain. The whole life or the family dynamics is going to change with this particular news. And this is most commonly a message which is actually telling the person that you have to change your choices in your life. I may want to have a long ride. I'm a person who wants to do certain things in my life. And this is a message that you're conveying me, telling that I may not be able to do all this that I want with my life. There are certain things which I may not be able to do from today onwards. So these are the things when you use the word cancer, when you are conveying the diagnosis unknowingly, these are the things that we are actually conveying, right? Your life is going to change, your choices are going to be limited. Now you have to go through all the treatment about the finances. Your job is going to change probably. There is no hope. So these are the things essentially we are conveying when we are conveying a bad news. So again, next question is to tell or not to tell. What do you think? Should we tell? I saw one response in the chat telling that patient has the right to know about the diagnosis. I totally agree with that. They have the right to know about the diagnosis. What do others think? Should we tell or should we not tell? What do you want to do with your patient? You want to tell your patient about their diagnosis, or do you want to tell their only their family, not to the patient? What do you think? I mean, it's okay to have both. Some people may want to tell your patient. Some people say it's not necessary, right? You can tell the relatives also. That's fine. Yes. So there are three people who are believing that we have to tell. Yeah. So there are some people which is telling it depends on the situation or condition of the patient. Evangeline is feeling that we can discuss with the family first. Yeah, and sometimes in our setting, the family has more authority than the patient to know and plan everything. So sometimes we end up telling the family first and then ask their permission. Yes. So I just wanted to ask your opinion. So yes, patient has the right to know about the diagnosis. At the same time, patient has the right not to know also, right? I can choose. I don't want to know. That's perfectly fine. If I don't want to know, I don't want. You don't need to tell. So yes, patients should know, but we know that in our situation, that's not really easy. Most of the time, till they die, they don't know what is happening to them. They don't know their diagnosis. They don't know what kind of tablets they are taking, why they are taking all this tablet, why they are going to a hospital. They don't know. Most of them. And very often, the family will tell you not to tell. The patient may want to know, but the family will come and tell you in the beginning that please don't tell. But why do you think the family don't want to tell? Because they think what if you ask, they think they will tell you these responses. Oh no, no, doctor, they cannot cope. They are not really strong to take this. She'll never be able to bear it. If you tell the truth, they are going to commit suicide. Right? Are these the common responses that you all face? We hear this very often. Please don't tell. He'll be depressed, he'll commit suicide, or he may not come for the treatment, he cannot take it, he'll become so weak, he'll become so hopeless. We don't want to destroy the hope. So these are the common responses that we receive when we tell about can we tell the patient. This is the first response. And this is nothing to harm the patient, right? Their intention is not yes, Richa, because the family members know better how the patient actually feel. Very true. I don't know how the patient was for last, what happened when there was something, some crisis happened in their life. I don't know anything about it, how the patient react, what kind of a person is that. I don't know anything about it. Family knows better, and family shows protective in nature. They want to protect the patient from all this news, life threatening issues. They want to take care of the patient really well, and that is exactly the reason why they don't want to tell. It is nothing to harm the patient, but it is about protecting the patient. And why we need to tell the truth? Because they have the right to know, first of all. And you know what? It gives time for us to plan. If I have a life threatening illness, if I have something which is a bad prognosis one, I need to know what is happening in me so that I can plan accordingly. Maybe only if I have only 6 months, there are certain things I need to finish in that 6 months, right? I may need to settle few things. I may have to write my will. I may have to prepare my children when I pass away. How are they supposed to? I have to tell my parents how to take care of my children. Who will take care of them? So I have to set a lot of things if I am going through a life-threatening illness. So it is very important to tell the patient because it gives them a chance to plan and cope, and it reduces the false hope. We say hospital shopping, right? They don't know what exactly is happening to them, they keep changing from hospital to next hospital, because here I am showing for last 6 months my disease is not coming down, I still have the swelling. They did the surgery, they did the chemotherapy, now I have a big wound, it is not coming down at all. I think this hospital is not really good. I have heard people telling good things about the other hospital. They may have to go to the other hospital. So you're unnecessarily spending money for something which may not be actually possible because we are hiding the fact from the patient. So it is better to avoid false hope, and it's always good to build that trust, because then they will know that the doctor is not going to tell you lie. They are going to be honest with you. So the patient in return will be really honest with you if you don't hide things from them. They don't you think from your personal experience, if you want to consult a doctor for something, we will like people that gives us honest information, right? Sometimes we know that they may be lying, or because we are all medical professionals they may not lie to us. But when you take someone, we like doctors or nurses who tell us the truth, not hiding anything. And if you tell them the truth, there is high chance that they are going to cooperate with our treatment. You tell something that, oh, no, no, this is nothing to do with the cancer. It is just a small swelling. It is not even cancer. And then you tell them, expect them to come on time for chemotherapy. Will they come? With a lot of side effects. They think, oh, I don't have cancer. Why should I go for the treatment? Doctor told you there is nothing to worry. It is okay. Why should I go for this treatment? I'm already scared of needles. I'm not going. So there is a lack of cooperation if you hide the correct news from them. But how do we know who can take it and who cannot? Like Richa was telling, the family knows whether they'll be able to take it. Family knows better about the patient, right? So how will we know that whether they can take it or they cannot take it? We don't know. We are seeing the patient for the first time, right? So it is not about to tell or not to tell. It is about how to tell. Like we always tell sometimes in fights in the family, it is not about what you told, it is about how you told it, right? It might be the same thing that you can tell in a different way. The same thing which I told, the reports have come, I have the reports with me, you have cancer. I can tell that in another way. I can prepare myself a little bit more so that it is not going to affect the patient as well as the family. So it is very important to learn that skill. For some people it comes very naturally, but majority of us need work, need training to train ourselves. It's a skill that you can learn. It is nothing like singing or dancing. Some people can sing, some people can dance, some people can paint, but communication skills is something that you can learn by practice. So there is a protocol called Spikes protocol. It is very well-known protocol in communication skill, especially how to communicate the bad news. There are six steps in Spikes. Many of you might have already heard the Spikes protocol. There are six steps in this protocol. This is to make our job easier so that we don't miss anything. The first S stands for setting the scene, how to get started. We'll take one by one later. And second step, the P lies for patient's perception. How much the patient understands. What does the patient know till date? The third thing, so we set the scene, we ask how much the patient knows or what do the patient know. And the third step is to invite the patient, inviting and asking how much they want to know. And the fourth is knowledge transmission, that is the sharing the information that we have with us in a particular way. I'll come step by each step in detail. And the E belongs to emotions, how to respond to the emotions. You're giving a bad news here. So we must know there can be reactions, there can be emotions, it can be a normal reaction, it can be abnormal outbreaks which can happen. So we must be prepared how to handle these emotions. And in the end, summarizing. So we'll take one by one. So it's like basic manners. We do that when you have guests at home, right? Or you're meeting someone. If you're going for a job interview, if you're meeting your superior, we all use the best communication skills possible, right? We know how to talk to people. But many a times when a patient is sitting in front of you with a life-limiting illness, we may not use it that much. We think that power ratio still exists, that we are healthy, we are healthcare professional, and this is patient with a life-threatening illness. So we'll start with the first step. The first important thing is to introduce yourself. Whenever we are going, so you might have heard that in basic communication skills also, it is important to introduce yourself. I'm a nurse, I'm coming from this and this particular ward, and I'm here to talk. So all these things apply to normal communication with the patient also, and make them understand who you are. They might be seeing 100 doctors and 100 nurses, right? So they have to know who is sitting in front of me. And these are already covered in the basic communication skills. Maintain the eye level. If possible, sit near the patient, sit down, and if possible, there should not be any barrier, and you should be relaxed and leaning a little forward so that they will understand that you are interested to learn and you are interested to listen to them. So the first thing is setting the scene. You need to understand what are you going to talk. whether you have the complete information. You can't just go back to the file, look in between, and talk to the patient. You have to go through the file, what all they have gone through, who all are there in the family. Your friend might have talked to the patient already. Ask them, okay, tell me about that patient that you have seen. I'm going to talk to them. So it is important to gather all the information, confirmed medical facts, what are the confirmed diagnoses, or if it is not confirmed, what is being suspected, what is the discussion happening in the background with the doctors and other nurses. So get as much as information. Your friend or the cleaner, so here what happens is that people who cleans the room, they might tell, oh, that patient is very upset, he's very angry towards his wife. So you know that this patient can be angry, you can anticipate that. So gather as much as information as possible regarding their illness, regarding their confirmed medical facts, their nature, who is staying with them. So sometimes they may say, no, ma'am, don't tell now because now she is alone. The son will come with food at 8 o'clock. Probably that time you can talk to her. She'll be relaxed after that. Or sometimes you are going at the lunch time. Probably that may not be the best time. So gather as many information as possible. And if you don't know, sometimes we don't know the prognosis, right? We may not have all the knowledge in the world. So we have a stroke rehabilitation project here. It's very difficult. Many things we don't understand what the neurologists say. So it's very important to make the call to the neurologist. Okay, sir, I did not understand what this medication does to this patient or why we are giving this particular medication. What is the prognosis? So get the knowledge. It is okay to ask around. It is okay to ask your colleagues or your doctor or anyone, but get the proper information. Because when the patient asks you, you can't tell, okay, wait here, I'm going to ask and come back, right? So get as many information as possible and maintain a private environment. So we have set the scene with your knowledge, with all the facts that you have, and providing a private environment. Next is to understand what does the patient know. Start from there with open questions like, can you tell me about your illness? Please tell me more about your illness. Or what do you understand from what doctors told about your illness? That is very important to understand. Sometimes they'll tell you in the beforehand itself, okay, doctor, I know that I have cancer, but I have not told anyone. Or they may say, I don't know anything about it. They just told to give a test and I don't know anything more than that. I'm waiting for the report. Now the report is with you. So we need to understand where exactly they are, then only we can proceed from there. And that time you don't interrupt them, just keep listening what they have to tell. So understood, you set the scene, when you ask what does the patient know, gather what they know, just listen till they finish. Then invite the patient. Ask how much you want to know. You can't ask that directly. Like, can you tell me how much you want to know? I can't, I don't have an answer for that. Ask whether they want to know about their illness, right? You told the patient has the right to know, but the patient has right not to know also. Some patients do not want to know. You can't force the information. No, 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 it's your right to know. I have to tell you. No, that may not work. So ask, do you want to know more about your illness? If they say yes, sometimes they say, it is okay. I don't want to know. Just relieve my pain. I don't want to know more about it. That time, do not trust information. Just finish the interview, give them appropriate hope. Okay, we will take care of pain, we'll help you to keep your pain as low as possible, which is an appropriate hope. I'm not going to tell that I'm going to completely treat your pain. I'm not sure about it, so I'll do as much as possible to reduce your pain and to keep you comfortable. If they don't want to know, stop the conversation there. I hope it is clear till now. Invite the patient how much they want to know. So, do you want to know about their illness? Sometimes, when we ask, the patient may tell, yes, I want to know. Please tell me. I've been waiting to know more about my illness. Then you start sharing the information. That is, now you have a bad news with you. Now we are going to share. Start with a warning shot. You can start that, okay, the patient might have told you last week they have taken a biopsy, they did some test and they told you have to wait for 3 weeks. Now I am here, I want to know what it is. So I may ask, Okay, I understand that you want to know about your illness. Do you still want to know if things are not really that great, that good? If it is the report is not good, do you still want to know? That is a warning shot I am giving, right? Now they know, okay, I'm not going to get something really pleasant. Something is there off. So they'll just prepare themselves, just pause there. So just give them time and then start with the diagnosis. Do you still want to know, or do you want to know even if if the report is not that good? It's an example, that's not the right statement or something. That may be one way that I might ask the patient or give the warning shot. Or you can say the biopsy report uh, doesn't seem to be the way we expected. Shall we talk more about it? So you have given the shot that okay, report is not really good, but can we talk more about it? So ask permission and then take a pause. So these are some of the example. It looks like what you have is not the usual or ordinary kind of swelling or wound. So you're giving them some alert. Okay, it's not going to be something normal. There is some problem. But give a pause there. Just don't keep giving information back to back. With the warning shot, take a pause there. What you have is something that may be difficult to cure or may not be possible to operate on. I've still not used the word cancer. So we gave the warning shot, then I am pausing there. Avoid medical terms and pause frequently. Look at their reaction after each sentence. The moment you tell, okay, this is not going to be that curable, or this is not an ordinary swelling, wait and look at their face and their reaction. Wait for some time, and if you think that they are ready to take the next step, then only you go to the next step. Check for understanding in between. Just ask whether they understand or do you want to repeat. Use silence a lot. And body language, look their body language also, like how uncomfortable they are when you are and encourage to have long sentences from them. Ask open-ended questions like, would you like to tell me what you feel right now? Can you please tell me what do you feel right now? So just don't ask, are you all right? Are you okay? Just give open-ended questions so that they give you not they don't give you monologues. Then comes the reactions. Once you have given the diagnosis here that I think you have cancer, that's what the report says. Give pause, keep silence, let them to vent their emotions or outbreaks or whatever they're going through, and give time to react. Just pause there, listen quietly, just don't interfere. If they are crying, that's okay, let them allow ventilation of all their feelings. Let them cry, let them be angry. They might start telling you, oh my god, that doctor was cheating me. No, I don't think I have cancer. I have been living with this for last few months. I've shown to this doctor, he told nothing to worry. So all those stories will come out. That time just listen, actively listen, nod your head and listen to them whatever they have to tell. Encourage venting. Just say and what do you think, what do you feel after what I've just told you? If they, sometimes patients just don't react, they just hear the word cancer and then they keep quiet, so we don't know what they are going through. So after silence, give them some time to react, respond. After silence, when it becomes so awkward, then interrupt, and or at least you should wait for 2 to 3 minutes. Then let them come up. If they don't tell anything, then you ask, what are your feelings after? What do you think, or what are you going through if after what I've just told you? And acknowledge their feelings. That I see you are very upset. I can see that you are angry. Would you like to tell me more about it? Then, once you deliver the bad news and then handle the emotions, then summarize. It's very important to summarize what you have already told. You tell them, okay, next step. If you think that they are ready, go to the next step, that any additional test needed, any additional information that they would like to know, what are the potential sources of support, what are the type of care that you're going to get, what kind of therapies that you're going to go through in the coming few days, and give your realistic hope. So it is actually like a prescription. It's the right drug. That is the information. Information is the right drug. You need to know how much should be given, right? You can't just give, okay, paracetamol is a good drug. Why don't I give 10 tablets? No, you can't do that, right? You have to know what exactly the drug is going to do. You have to know the right dose, how much you should give. You can, sometimes we may have to stop the conversation. They may tell you, yes, I want to know. Then I give the warning shot. Okay, things are not going to be that great. I don't think the test reports looks like. Then they may say, doctor, that's enough for today. Can we talk tomorrow? Stop it there. So we may not be able to finish the whole conversation that day. So understand how much to give. Make sure that they are ready to receive. They are there. It is okay to proceed. So every time you check that whether you can go proceed to the next step, and give according to the patient's emotions or the reason they want to know, they want to plan, and the patient asks you, and it should be given at the right time, not when someone is hungry, someone is waiting to go outside with their family, when they are in terrible pain. No, you have to choose at what time, not at the end of the day, night, or sometimes when they are very tired after some medication. So choose the right time and right dose, as I said, in bits. And in between the bits, we check during pain, right? You give morphine at 6 a.m. and then you check the pain at 10 o'clock. Do you have pain? Same way, you give the dose a little bit and check whether they are okay, whether they are okay to take the next dose. So, how can we reduce the unpleasant experience? We have to prepare properly. We have to be honest, but it has to be very, very gentle. You can't just stay. So, honesty, we saw. I have your reports, you have cancer. I'm very honest there, but I am not, I was not gentle. So, it's very important to have gentleness as well as honesty. And the language is very, very important. If you say cancer, also, some of the rural areas, people don't understand what is cancer. Sometimes you have to use the language that they understand. Sometimes you have to draw pictures. Okay, cancer is like this. This is an illness. This is your body. How it is going to affect you. So pictures can help people to understand what exactly is going through. They are going through. And if they don't want to know, if they don't want to listen, do not trust. Oh, now I have learned communication skills. They told you have to tell the patient. Patient has the right to know. I have to tell this. No, do not trust the information if the patient doesn't want to know at all. Give them time. So someone mentioned in the chat in the beginning. I think it was Liana that give them time to prepare. So many patients tell that I was stuck with the word cancer, ma'am. First they told, then I didn't hear anything about it. So I was interviewing a 20, late 20s. He was diagnosed with CA rectum. So I asked him what he went through. How did the doctor tell you? How did you take it? So they were talking about the sperm preservation and all, because he's very young, he's not married, because he's going to undergo radiation. He told, I did not hear anything. I was still there with the word cancer. After that, the doctor kept telling. I could not listen. I was blank. I just saw their lips moving. So it's very important to give that time to sink the information. And don't give unrealistic hope that everything will be all right, we'll take care of everything, or this is completely curable, don't worry about it. Don't give inappropriate or unrealistic hope. Give appropriate hope and what all treatments are available, and offer continuity of care. Then now we have to know whether there were some chats that we were telling, whether to tell the patient or to the caregiver, and when to tell. Sometimes when the disease is progressing, or when the patient is in advanced stage, or the patient is nearing end of life care. So this is exactly what we follow here. We don't tell when it is being diagnosed. Very often, when the disease is progressing, then we tell the bad news. Or when they are in the advanced stage or in the terminal condition, then only we generally convey the bad news. But that's not the right way to go about it. And how to effectively communicate: ask before telling. Check. I'm emphasizing it again and again because we sometimes become over enthusiastic because we have all the information. We really need to help the patient. It's so compassionate. Now we need them to go through the treatment and get cured. We are so enthusiastic to help, and then we tend to give all the information. No, ask whether they are ready to take the information. Pause in between and check their facial expression. How do they react? Are they becoming restless? Are they looking here and there, breaking the eye contact, looking down, crying, probably looking in the distance and crying, probably? So take the cue from the patient. Then you know that you have to stop. Better you stop the conversation, or better you give a touch and acknowledge their emotion. Like, I can see you are upset, I can see you are angry. So acknowledge, name the emotion and acknowledge the emotion. And give open-ended question. Can you tell me, what do you think after what are you feeling after? Now we have discussed about the diagnosis. What you're feeling now. So ask open-ended question and be empathetic. So I'm just summarizing it. Setting this, the spikes protocol. S is for setting the scene, where you have to gain as much knowledge and facts as possible and create a good environment where you can have a private talk. Understand what does the patient know. Invite the patient. Do you want to know more? Would you like to know more about your illness? Share the knowledge. Whatever you have, share only that patient wants to know, not everything that you know. Understand or pause and acknowledge their emotions, and in the end, summarize what you have told, what is the treatment plan, what are the options that are available, what is the support system that is available. Summarize the whole conversation possibly. So, to just to tell where we started, to patient has the right to know. Again, patient has the right not to know also. Not telling them actually may cause more harm. Like I said, they may go from one hospital to the other thinking that the cure may be possible, right? They may end up spending a lot of money. They may have high hopes that, okay, I am going to go for higher studies after the treatment is being done. They may be dying, we don't know. So it's very important to, if you don't tell, it is going to cause more harm than good. And do not tell if they don't want to know. It is not about whether to tell or not. We have to tell ideally. If they want to know, we have to tell. But it is about how to tell. How you, I am telling that you have cancer is very important. I'll just take my second PPT. The rest of it will be talking about collusion. Meanwhile, I can take up a few questions while I'm loading the second PPT. If you have any questions in the chat. So, are there any questions whether to tell or not, or what do you do when the family doesn't want the patient to know, but the patient is an adult and has the right to know? Yeah, yes, Liana, we are coming to that in under collusion, and that is the scenario almost 90% of the time in here in the country. In the place that we work, I guess most of you will agree to that. The relatives do not want us to tell the diagnosis to the patient, right? Very often they'll tell you, please don't tell. I know everything. I know that patient is dying. That is okay. I'll take care of everything. I'm giving going to give the best possible treatment, but uh, don't tell. I'll take care of it. So that's very. common scenario. There are no other questions on breaking, communicating the bad news, then we'll move on to the collusion. So this is the word collude means to act together secretly. It's not in a good way, okay? It is not about helping someone by colluding, but it is about deceiving someone. It's a secret agreement between two people, something like a dishonesty, like you two people agree that okay, let's not talk about it, and deceiving a third person. So usually it is used in business terms where they say two companies had colluded to fix the prices, or you might have heard in scandal news that two people have fixed the rates and they colluded and they did this in the market. So usually it is used in business world, but essentially it means that conspiracy of silence. Two people agree to keep silent, to hide something from a third person or to deceive a third person. So it's not a really a positive term. It's not a good natured one. Generally, it has a negative meaning. It is very, very common. Either the doctor will not tell the patient or the family, all the healthcare workers will know, but they don't want to tell. Sometimes the family don't want to tell. That is the most common scene scenario in our setting. Very often they may tell you, they will enter into the clinic first before the patient and tell you, my father is going to come next, please don't tell him about the diagnosis, we know everything, that's enough. They'll just quickly come inside, tell and disappear. Then you are stuck. Okay, what do I do now? So it's slightly different in other countries, maybe in the West, where the patient tell the doctor not to tell my family. But it is exactly opposite in our place where the relatives tell that please don't tell. I know that my father has cancer. So why do they ask us not to tell? We heard that it is an act of love. They know more about their loved one. They know how are they going to react. They know that they need to protect their emotion. They don't want their loved one to be so vulnerable hearing to this news. They don't want to give another pain for their loved one. And I think okay, I'm able to handle it. So what is the harm? Most often the relatives they believe that the patient doesn't know. Imagine a patient is going to a cancer center every day for 21 days for radiation. They are sitting in front of the cancer ward. They are seeing cancer patients all around. They have a clue that they have cancer, but the family has not talked to them and they don't want to talk. So both of them don't talk about it. Such a stressful situation in the family. Imagine that you can't talk about it in your own home. You are pretending that you don't know. Your family is also pretending that they don't know. So it's all about, it takes a lot of energy in a day to day thing to hide all this information. You can't have an open conversation. You try to avoid seeing them. What if they ask me? So they think that the patient doesn't know the diagnosis, and they think that what if they decide to die? Am I going to kill their hope? What if they give up? What if they don't continue with the treatment if they know the truth? And they think that no, my dad is unable to cope. He can't take this news. And it is my responsibility to protect the patient, right? I have to take care of my dad if he is unwell. Why should I give him the pain of this news? That is there on one side. But what it actually costs, this is their intention on the left side. But what is actually happening? The family and the patient isolation. They don't talk to each other. They want to avoid the awkward situation at all. And no one talks to them and the patient feel worthless. Everyone is standing outside the room and talking something to the doctor. I don't know what is happening. See, they have taken away that from me. I was the breadwinner of the family, I was the boss. Now they are not talking. They are deciding what I should do. I should eat, where should I get the treatment from. I'm not involved in any of the decision. So they feel a sense of worthlessness. And what are the bad effects? After some time, you can't tell the truth because you have seen no one small lie, then you have to keep lying. At some point, you may not be able to tell the truth at all. And what happens? So I still remember one of very very close person to me. He was very sick. So I used to meet him almost every day. And one day he told he's not feeling well, he has stomach pain, so he's going to hospital. So after a week, and there is no news, and I called the family and asked what is happening. So he was my teacher. So I asked what is happening. So they told no, he has stomach pain. We are taking him to hospital. Now he's fine. So then I asked, shall I come and see him? They told no, 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 no. He's taking rest. I understood as a palliative care doctor that there is something wrong happening there. I just assumed that probably he may have some cancer. And I wish, okay, this should not be cancer. I kept asking, but why he is so unwell? If he is treated, he should be able to get up. They told, no, no, because he is very old. We told him to take rest. He is lying down. So please don't come and please don't tell anyone that he is lying down. So it was so difficult for me as a palliative care doctor, not visiting my teacher, whom I have been seeing every day almost. I really wanted to know what is happening. They prevented everyone visiting there, and within 2 weeks, I got a call telling that he died. He had CA pancreas. So they knew that it is not treatable, it was very advanced, but they didn't want anyone to visit him. And he was actually calling people and telling that I don't know what is happening here. These people are not letting me to get up. They are feeding me on the bed. I'm actually not that sick, but they are treating me like a patient. I don't know what is happening. Can you talk to them and let me know what is happening here? So, see the tension happening in the family. No one could visit him. He wanted to see people. They could not talk to each other, and no one was allowed to go there. So, everything happened. And the patient will be in so much of anger that everyone is talking something outside the room, only I am not doing anything. And this can lead to chronic anger. He'll be angry to everyone. And then false hope, lack of trust. They stop trusting anyone. Okay, I know that there is something there happening inside my tummy. They are not telling me the truth. I don't trust anyone anymore. And what if he has unfinished business? So, my teacher, what if he had unfinished business in his life? What if he wanted to do one more thing before he goes? One last lecture? Something. So, we are preventing them from doing that. Creating legacies. What if I want to write a whole diary to my children that how much I love them, or how should they do things? You're taking away that chance from me, right? I'm not prepared to go. You're not telling me. So I can't create any legacy for my kids. It can be a picture, it can be a note, it can be talking to them. So there can be unfinished business, and this can lead to suicidal tendencies. Because I don't know what is happening. Everyone is talking, I am not knowing what is happening. I'm so angry, and this can lead to depression and ultimately suicide. Points to remember when you are planning to break the collusion. You have to understand that mentally competent adults have the right to take decisions about their own care. And it is very, very unethical to keep the truth from patients when they are willing to take it. So the patient is so the son is coming and tell you, don't tell. And next comes the patient is telling doctor, everyone is hiding something from me. At least you have to tell me what is happening. What will you do then? Will you tell? The patient is asking you, sitting right in front of you. Just let me know through the chat. Will you tell or will you not tell? The son has warned you, please don't tell. None of the doctors have told, but the patient is asking you. How will you go ahead with that? Anyone? Just, I don't need the right answer. I just want to know what will you do? The patient is sitting right in front of you and asking you. But Kanchan, the sun is going to blast at you. He's already told not to tell. How will you handle the sun then? You may need to escape from another road, I think. So Gurpreet is telling we do not tell to the patient, but patient is asking you, sitting right in front of you, what will you tell? You have to give some response, right? You can't just keep no, you have to tell something. Will you tell that I don't want to tell you, or will you tell that I cannot tell you? Yes, Kanjan, definitely the patient bear the treatment. So imagine a situation, the son has told you, sister, my father is going to come for the chemotherapy, please don't tell. We have gone to multiple places, no one has told him, so please don't tell him now. He won't be able to take it. Then the patient is coming and asking, Sister Kanchan, please tell me what is happening. No one is telling me. And with lot of compassion, you remembered all the spikes protocol and you delivered the news to the patient. The patient goes out and tells the son that, okay, I know the diagnosis. Now the son is going to be so angry. Do you think the son will next time take the patient to you? Or will he go to some other hospital? Anyone else? What will you tell? The patient is asking you, and the son has told you. Yeah, we do not tell the exact diagnosis, maybe give some idea. Yes, this is a very difficult situation, and we all go through it every day, right? Liana is telling it would be good to ask the son on the importance of telling the patient, then the patient has the right to know. So it's important to have a conversation with the son. So I'm just so the first thing is to acknowledge the family's concerns. We know that the son is trying to protect the father. It is not to harm you. It is not to insult us or anything. He just want to protect this his father. We don't know how to deal with this whole situation, right? So just acknowledge, telling that yes, I do understand that you are very concerned about your father's illness. Acknowledge that I understand how much you want to protect your father. That itself will calm him down a little bit. Okay, this person is understanding at least what I'm going through. Just make him sit down. Okay, I understand that you're concerned and how difficult it is for you as a son to go through all this. So acknowledge that. Then explain the benefits of telling. Okay, so the first thing will be no, no, sister, please don't. He will faint. His BP will shoot up. He'll suicide. So ask, what are they worried about? If it is suicide, or if it is BP shooting up, if it is fainting, if it is giving up, you are there to help with that. We are not going to abandon you, right? You're not going to tell directly and then just abandon or just escape, right? So explain the benefits of telling. What are the benefits? And tell them that, see, he has a right to know. Tell them that he may have unfinished business. He may want to tell you something. He may want to share something with the family before he go through all this treatment. So make them understand the benefits and make them understand that, see, the patient has a right to know. What if, like, we all have the right to know what is going on in our body, right? And then ask, do you think he suspects the diagnosis? Did he ask something about it? Very commonly, yeah, he asked, why am I in a cancer ward? Why are you bringing me to a cancer hospital? Then I say, no, no, this is not just for cancer, these are for other illnesses also. This is a common answer that we get. Oh, this was initially a cancer hospital, now it is not anymore. They have not changed the boards. These are the answers that they give their patients actually. And the poor things, they believe it. So ask, do you think he suspects something? And how does it make you feel as a person? So acknowledge the person in front of you, acknowledge the son. It must be terrible when they ask you, right? You will be in trouble, you will have to tell a lot of lie, you will be in stress. Usually they'll start crying. Yes, I am going through a lot of stress because I can't have this discussion at home. Then only offer your help. Explain the harmful effects. What if you don't tell? And acknowledge, telling that I know that how much you love your father, and I can clearly understand why you are telling me not to tell. It is quite common. I understand that it is out of your love that you are telling. So it is very important to acknowledge the son and explain the benefits, that what if he wants to write a will, What if he wants to fulfill some wishes, some marriage in the family, some graduation ceremony, something that he wants to convey? They simply have the right to know. And when you are preventing or hiding, how does it make you feel not telling him? It is you also are going through a lot of discomfort by not telling. And do you think that he knows something? And then we try everything. We may not mean. Sometimes the son will tell you, I understand everything, but don't tell. We may have to stop there. Maybe you can try during the next visit. But many a times they will tell, okay, let me think. Maybe next time you can tell. Or sometimes they say, okay, I'm not able to tell. If you can tell, please tell very gently and please offer support, then you can proceed. We may not win all the time, but it is the way that we should. So initially agree to collude. When the son is telling me first time, please don't tell, I will tell, okay, I won't tell, but I want to talk to you after this. So then I'll call the patient, I'll see the patient. Sometimes the patient asks you, doctor, what is happening to me? So I'll tell, yes, next visit when you come, I'll definitely we'll be sitting together and have a conversation. I'll give the time. Then I'll call the son. If I don't have that, okay. Then you start the conversation. Okay, what are you going through, or what are your concerns? Why you are telling not to tell? What are you afraid of? So start having the conversation with the son and the family. So collusion is actually hiding the truth, and it is basically to protect their loved one, but it gives more harm than good. So it is always start by acknowledging the family. Don't why are you telling like this? You have to tell the patient that it's the patient's right to know. The patient is never going to come back to you. Oh, that nurse or doctor is very rude. They are going to tell my father about the diagnosis. I'm not going to go there anymore. Who is going to suffer? The patient is going to suffer. So first have a rapport with the son who doesn't want to tell. It can be son, it can be an uncle, it can be multiple people. Have a rapport with them, understand, acknowledge their feelings, understand why they don't want to tell. Just be with them, just have a good communication with them. Then your door will open to the patient. Then it is easier. With their consent, you are telling the patient. And if the family is telling that no, I understand whatever you tell, but just don't tell. But keep the door open. Okay, whenever you feel like you want to have this conversation, please let me know. I'll tell them. So keep that door open. Next time when they come, no, I already told you to tell, you didn't agree. Now you are telling me, so don't respond like that. Just offer them help whenever they want. So I'll stop sharing and I'll take up a few questions. It's not that easy all the time, but it's, we have to try all the time. You may not succeed all the time. Sometimes they are still in the phase that please no, no, I'm not ready to tell. That is okay, but you have to try 100%. It takes a lot of time and patience and skill. That's very important. What words to be used, what sentence to be used, how to present this, whom to address, who all should be there. Sometimes I call my nurse to be sitting with me to have this conversation. I may not be sitting alone because sometimes they have a good rapport with the nurse than with me. So I'll ask, why don't you also come? I'll ask them, would you like to call someone else also to sit with you, or you want to be alone? Sometimes they say, yeah, I think my wife should also be here, or my husband should also be here. So ask them before starting the conversation whom all should be there. And from your team also, who is the best person to have this conversation? You want your counselor to be sitting with you, or you want to go alone, you want to take your nurse. So decide among yourself. So I can take up a few questions before we start the case presentation, maybe just 2 minutes or something. If there are no questions, we can start the case. I hope the lecture was clear because there are no questions. So I was wondering, this is usually a session where people do get a lot of confusions and questions. So I hope it was clear. If there are no questions, we can start the case presentation.
Today we have a case presentation by Mr. Gurpreet Singh. Mr. Gurpreet, can you please take up?
Hi, good afternoon to all of you. Thanks for being a part of my case presentation. And here I'm Gurpreet, and basically I'm from Mohanday Oswal College Hospital, sorry. And here I would present my case presentation. So can you please share the screen with me?
Yeah, it's already been shared. Can you see the screen?
No, actually I'm unable to see the screen.
Can others see the screen? It's shared actually. Can someone respond? Can you see the?
Yes, ma'am, I will see.
Okay. Gurpreet, can you just scroll and see whether it is visible in another?
It's not visible right now.
Uh, can you just scroll and see because it's visible to everyone?
Just wait, I'll check.
Yeah, I'll take a question till then. Nancy has a question. Sometimes both are willing to share the details and started in between. The patient started to be violent. What can we do? Violent in the sense getting up and starting to. If you think that they are going to beat you up, just get up and escape. Just run away. That's all. Because we see that in news every time, right? People are getting beaten up. If you mean violent, if it is anger, that's fine. Just be there, just maintain your pause, just be there. So anger is something like venting the emotion. They'll be angry towards all the healthcare professionals in the world. The doctors are cheaters, they are there to make money, you are trying to cheat me, that hospital is like looting money. They can be angry towards themselves and god and everything. Just be there, don't try to touch or convince or anything, don't try to interrupt. Once they are coming down, they will come down. After the initial venting, generally they come down. Then you ask, would you like to talk more about it? I understand that you are angry. Are you okay to talk about it right now? So violent, yes, you may have to protect yourself because that's not something that time your listening skills may not work because violence is something medical legal thing. We are not getting into that. You just have to take care of yourself. Just run away. But if it is anger, then just be patient and wait for them to vent all the emotions. Once it is out, it is out, and you will be the best nurse ever once you have that patience to listen to them.
So,
Yes, Gurpreet, yeah, please.
so everybody may screen my screen as well.
We can see, but not the presentation. Have you started the presentation now?
Just wait, ma'am.
Yeah.
Now it's visible.
Yeah, it's very small, but yeah, it's like we can see a series of slides.
It's okay right now.
Yeah, it's not readable, but you can read, then we can listen. That's okay. Yeah,
Sure.
now it is good. Now it is good to do.
So patient Mr. X, age 45 years old, and gender is male, and patient diagnosed with CA lung with metastasis, bone and brain mets, and obstructive pneumonia. And presenting complaints was whenever patient come to the hospital, there was difficulty in breathing from 2 days, pain in chest from 10 days, pain in chest from 10 days, nausea and vomiting from 2 days, weakness from 5 days. So history of illness is 45 years old working man, onset of disease May 2021, and mode of the disease is the chronic smoker. Personal history of the patient. There is no any history of the comorbidities like diabetes mellitus, hypertension, TB, no history of any medical and surgical illness, and history of smoking from 15 years. Family history, there is no any history of comorbidities like diabetes, hypertension, TB in family, as well as malignancy. So physical examination reveals height 154 centimeter, weight is 65 kg, thin build and undernourished, afebrile, heart rate 120 beats per minute, respiratory rate was 34 per minute, beats per minute, breaths per minute, BP was 140 by 70 mm of SG, SpO2 92% on oxygen support. That was 3 to 4 liter. Journal examination reveals conscious and oriented, skin is intact, CVS, pulse regular, tachycardia is present, S1, S2 heard. Respiratory system reveals shortness and difficulty in breathing. CNS, GCS, journal condition of the patient is Glasgow Coma scale of the patient is 15 by 15, normal mobility. Musculoskeletal system reveals weakness in limbs due to the poor nutrition pattern. Pain score was 4. So treatment and significant investigations are received the first line chemotherapy, that is the injections is plantain on July 2021, and cyclophosphamide are administered frequently as a single agent. Cisplatin administered a dose of 100 mg by Vitasco IV per cycle once every 4 weeks. Palliative chemotherapy, second line treatment injection carboplantin 450 mg injection is used in the treatment of ovarian cancer and small cell lung cancer, and it shows it's working by the stopping and slowing down the growth of the cancer cells. Third line treatment is the injection paclitaxel, that is brand name from Taxol, along with the albumin bound. Investigations. So here the investigations are from the first one is the lung biopsy. Pleural tissue, the above described feature as consists with the poorly differentiated metastatic adenocarcinoma. Based on the morphology and the immunohistochemical profile, some of the possibilities may include upper gastrointestinal tract and pancreato-biliary tract. Apart from this, CT chest plus perform. CT chest reveals multiple pulmonary nodules, some which are solid and some of which are ground glass, with little significant change in March 2000. It's for Manatha May 2022. However, as compared with the May 2021, in the lingual pacification has deficiently increased in the size. There is also a new ground glass focal opacity measuring about the centimeter in the right upper lobe. The findings are concerning for the recurrent adenocarcinoma. Another blood investigations were CBC, LFT, RFT, and other necessary parameters are done as per the doctor's order. Psychosocial aspects. Patient is from Ludhiana and he has 2 children and they live in Ludhiana. Husband is serving his duties, are also affected. No one else in their family support for their long-term treatment. No able to have proper diet due to the illness and low socio-economic status. Health education for palliative care and supportive management to be given. Diversional therapy is also given. Medication treatment is injection MSET 8 mg IV 8 hourly. Injection paracetamol 100 ml IV SOS. Nebulizer with Dulin and Bidicot 8 hourly. Injection Tezec 4.5 mg IV 8 hourly. Syrup Alex 5 ml per hourly 8 hourly. And injection Tramadol 50 mg IV 8 hourly. So basically, AMSET is the ondansetron and basic properties of antiemetic. Paracetamol is the as well as antipyretic and analgesics. And nebulizer Dulin Bidicots the properties of the bronchodilators, as patient have problem in difficulty in breathing, and productive conversion. Injection Tezect is the antibiotic and contain tazobactam and sulbactam. Syrup Alex is it's a Also a antitussive agents. So injection tramadol is the analgesic properties. So main concern is propagation of disease as detected as at advanced stage, pain in chest, shortness of breath, nausea and vomiting, poor nutrition, meats to brain, lungs and skeleton. Carry out daily activities only with the support. 45 years old man detected with lung cancer, started with chemotherapy, had disease progression with metastasis, now on palliative chemotherapy and supportive management. Discussion points are pain management, control nausea and vomiting, promote respiratory pattern, nutritional buildup, individual counseling, family counseling. In pain management, we ideally just prescribe the treatment to the patient. Some of the painkillers are there. Control nausea and vomiting, specifically the injection AMSAT, that is the ondansetron, as we prescribe the patient. And respiratory pattern was improved after some oxygen therapy, bronchodilator agents, and as well the oxygen therapy. And we should elevate the patient's head at 45-degree, and proning position is also given to the patient. Nutritional buildup is small and frequent diets given to the patient. Individual counseling as patient counseling according to the disease condition, and family allow the family for that family allow for the that the patient just want to know, and we just simply tell the patient that he have that kind of problem. So thank you.
Thank you, Gurpreet. I would like to hear from others. Would you like to suggest? I am sure that you have sessions on upcoming sessions on nausea, vomiting, and breathlessness. But if others have anything to comment on, I would like to hear from the participants first before I take up those questions. Thank you for the detailed presentation, Gurpreet.
Thank you, ma'am. Thank you.
Any medications that you would like to suggest to for a better pain or nausea vomiting control or the breathlessness?
Yeah, injection perinom is also there. As the patient is not managed with the injection ondansetron AMSAT, then
Okay.
we yes give the perinom injection to the patient as per dose require order by the physician.
Okay. Thank you. Anything
Apart
else
from
from?
the
Yes,
apart from
please.
the yes apart from the bronchodilators, as we prescribe that steam inhalation to the patient, and other agents that will cure the cough and other problems of the patient.
Thank you, Gurpreet.
Thank you,
Anything
ma'am.
from others? Yes, Kanchan is telling that there is injection tramadol 50 milligram 8th hourly or 6th hourly, something is going on. So probably if the pain is still not controlled, she's telling to follow the ladder. Probably we can think of step 3. Is there any added advantage if you are going to step 3? Anyone of you in this particular patient? I may probably go to step 3 with an added advantage of one more symptom that can be addressed with morphine other than pain. So, what can be the causes of vomiting in this patient? I'm not going into details because you have a detailed session on nausea and vomiting. But what can be the possible causes of vomiting and nausea in this particular patient? Anyone in the chat or unmute?
Good evening, ma'am. Tramadol can also cause nausea and vomiting. This
Yes.
is a big reason of nausea and vomiting.
Yes, very true. Tramadol, even if you give antiemetic many a times, people, especially injection tramadol, is very, very emetic. Any other causes? We don't know about the bowel habits. Tramadol can cause constipation, not just morphine. It's a step 2 opioid, it's a weak opioid. It also can cause constipation. So sometimes we see patients end up in having nausea and vomiting. Anything else from his diagnosis which can cause nausea, vomiting? Definitely chemotherapeutic agents, probably. Anything else from his diagnosis? He has brain mets, right? So there are chances of raised intracranial tension. Yeah, I guess he has brain mets and bone metastasis also. So there can be chance of hypercalcemia, induced vomiting. There can be chances of raised ICT, intracranial tension, induced vomiting. So there are, I'm not going into details, but that is how we have to approach each symptom. What are the reasons for vomiting? So these are the reasons for vomiting. Then we may have to, if it is due to raised intracranial tension, we may have to use something to reduce the ICT, right? You may have to use medications for that. Or ondansetron or metoclopramide may not work there. What if it is due to tramadol? We don't know. What if it is due to constipation? So I will deal with that in detail. But when we go to step 3 with morphine in this particular patient, the one added advantage is morphine is the drug of choice for refractory breathlessness. Small dose morphine is very, very effective in treating dyspnea. So this patient has breathing problems as well as pain. So I would choose to give step 3 opioids so that the pain is taken care of and the breathlessness is also taken care of. Right? So again you will have another session on breathlessness where you will learn how to prescribe morphine for breathlessness. It is not as same as we prescribe in pain. Anything else from any other participants? What about the nutritional support? What do you think about it? What are your thoughts about improving the nutrition in this particular patient? How can we do that? Do we need to do that?
Yes, ma'am. Obviously, it is important because as the nutritional pattern is important for the patient. As the nutritional pattern is totally disturbed, so we just encourage the patient to take small and frequent diet. If he or she will unable to take the whole diet, then small and frequent diets are there. Even if patient is no completely refused for the diet, then we go for the NG feeding as well and TP and total parenteral nutrition. In on those patients, those are unable to take or
Thank you, Gurpreet. Thank you for your response. Anyone else would like to comment on that? What is your take on this particular patient who has lung cancer with multiple bone brain metastasis and deteriorating? What is happening to this patient? What is the illness trajectory that he is on? Is he going through a good prognosis? What happens in advanced malignancy? So I think you should all probably go back and read a little bit about anorexia cachexia syndrome, how people lose their weight, and how futile in this patient, in this particular advanced malignancy cases, how futile is giving artificial nutrition. The body is unable to metabolize or absorb. So how much ever we give as the best possible parental nutrition in the world, the people will still lose weight. That's what happens in anorexia cachexia, right? They are not feeling hungry, then we end up in giving artificial feeds, but they still keep losing weight. So, just if anyone is interested, what happens to the body when in advanced malignancy, just read about anorexia cachexia syndrome. I'm not telling that you should not feed or anything, but sometimes it's a body's natural response when they are deteriorating. They stop feeding many a times. Even if we give artificial nutrition and hydration, that is going to cause more harm. There are a lot of studies on the impact of nutrition and hydration in advanced malignancies. Sometimes we may have to limit our the nutritional supply to a minimum. Again, that will be covered in the end of life care, but that is for you to understand. So, probably I would manage this patient by start thinking by what is the cause of nausea and vomiting. Will should I, as Sister Kanjan was rightly mentioning, should I go to step 3 because morphine has effect on breathlessness also? So should I go to low dose morphine? I have to ask about the bowel and bladder pattern. Again, I have to consider the ICT can be a reason for nausea and vomiting. There, my antiemetics may not work. I have to give something to reduce the edema there. Then only the nausea and vomiting will come down. Again, supporting or communicating to the family and to the patient that I understand this is a bad prognosis because someone with brain mets and bone mets, the survival is very, very less, even after palliative chemotherapies. So I may have to talk to the patient. Uh, Maybe with some of the newer immunotherapy, he may survive longer. But otherwise, it's very important to have the conversation that because the family will be really worried about he's not eating or drinking, he's losing weight, he's looking so thin, he's very weak. So I have to talk to them what is exactly happening to someone's body when they have an advanced cancer or when their prognosis is really bad. What exactly? Why do they lose weight? Why do they don't gain weight even if we force feed or you give an G tube or you give a TPN? They don't gain weight, right? They keep losing weight. What happens to the shift in the metabolism? So all these things I have to use simple terms and make them understand what is happening. That's how I would go with the patient. With the case, I will ask them, do they have more questions? What do they want to know more about the illness? Before that, I will talk to the treating doctor to understand where exactly this is going, what are their plans, because the next thing they will ask you, okay, what is the plan then? We don't know. So I'll go first to the consulting doctor and gather as many information as possible, and then go and talk to the patient and the family. I'm stopping there because if you, any one of you have any questions, I'll take that up. Gurpreet, I understand I did not tell any medication for nausea, vomiting, or breathlessness because we have sessions coming up specifically for managing those symptoms, which will be discussed in detail during those sessions. But I'm just touching upon how we are going to proceed with that particular patient. Any other comments? If there are no other questions, maybe we can wind up today's session. If you have more questions, please send us in the WhatsApp group or send us emails. We'll get back to you with the answers if you have any queries that you were unable to ask today.
Thank you all. Special thanks to Dr. Sreedevi for joining us today. Thank you all for joining us today. Have shared the feedback link in your chat box and in your WhatsApp group also. Kindly do fill it up. And one more thing, the last date for submitting your assignment 1 is today. Please do submit it today itself. We'll see you on the next session. Bye.